Welcome to Women in Sarcoma case presentations. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. When you submit your question, it will be visible to all panelists, but will not be visible to other attendees. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the VP of Program Services, and I am your moderator for today. I would like to introduce our panelists today. Dr. Vaya Floro is an assistant professor in the Division of Oncology at Huntsman Cancer Institute at the University of Utah in Salt Lake City, Utah. Her clinical and research interests are focused on sarcomas and gastrointestinal malignancies with an emphasis on immunotherapy and targeted therapies. Dr. Kira Kelly is a medical oncologist at Memorial Sloan Kettering Cancer Center, who has expertise in treating and researching bone and soft tissue sarcomas and Merkel cell carcinoma. Dr. Kelly's research aims to develop new and more personalized therapies to treat sarcomas. She is actively involved in developing and designing clinical trials that will look at novel agents that target molecular changes within tumors. She is also studying innovative combination immunotherapy options that will harness a person's own immune defenses to fight their cancer. And since 2008, Sandra Bracker has been a nurse practitioner with the UCLA Sarcoma program. Her patients are fortunate to benefit from her experience with managing the care of all types of sarcoma, bone, soft tissue, and GIST throughout all stages, from newly diagnosed, undergoing treatment, clinical trials, surveillance, recurrent disease, and survivorship. We're very fortunate to have these ladies with us today, and I would like to welcome Dr. Floro to begin the case presentations.
Oh, thank you, Sarah. All right, so good morning or good afternoon, everyone, depending on where you're at. So thanks for the invitation. I'm going to present a case that I took care of when I was actually a fellow, and it's a short presentation, so it won't take the majority of the time, hopefully. So to start off, this was a 32-year-old woman who had literally no other medical problems, and she presented to an outside hospital, community hospital, when she was 21 weeks pregnant. With left-sided abdominal pain and cough. And those symptoms started approximately 5 weeks earlier when she was around 16 weeks pregnant at that time. So initial imaging at that hospital showed, she underwent an ultrasound, and that showed a mass coming off her stomach. Subsequently, she had a CT of the abdomen, which showed, as you can see here, quite a big mass coming off her stomach, as well as a few liver spots suspicious for disease involvement. And as you can see, the mass is quite extensive. It's pushing down the spleen here and the left kidney as well. So her symptoms were not really controlled, and she ended up having a surgery where they removed part of her stomach along with the mass and splenectomy. During the surgery, unfortunately, the tumor ruptured, and they removed the tumor in pieces, which is it's a very suboptimal procedure for a tumor, for all tumors, especially for GIST, as you probably already know. And she, at the same time, she also had biopsy of the liver lesions to diagnose the pathology. So the pathology returned consistent with a gastrointestinal stromal tumor. As you see, the mass was more than 20 centimeters. And the tumor did have the KIT exon 11 mutation. And the liver biopsy was also consistent with the same pathology of GIST. After that surgery, she had quite a few surgical complications. So that was the reason she was transferred to our center at that time for further management of those complications. And when we saw her, we ordered a circulating tumor DNA, and I'll explain later why we did that, but we were able to detect the same mutation that was detected in the tumor. And as you can see here, this is just a graph showing the KIT mutation was present 6.3% of all the total circulating tumor DNA. And I'm going to pause here and ask my fellow panelists as to what they would do in this case. I mean, obviously I will say later what we did and what we considered the most important factors to be at that time. But just as a caveat, there's obviously, I think there's no right management, right? It's an individual decision we had to take. So I just want to get Dr. Kelly's and Sandra's input as well as to what they would do in this case.
Yeah, thanks. It's a great case. I think this is a really difficult situation, but thankfully we don't find ourselves in too often. I guess the concern here is this lady has stage 4 disease with an aggressive type of GIST given the KIT mutation present. However, she's 21 weeks pregnant, and therefore they're using tyrosine kinase inhibitors during pregnancy. There's some data, I guess, from CML, but there's not great data, and we don't have great data in GIST especially, and GIST is obviously a very different type of disease, and in her situation, in this patient's situation, I think you really need to have a risk-benefit approach, and also I would be consulting the maternal fetal medicine as well to get their intake on things regarding the viability of the pregnancy. And but I think the question is, should we consider initiating imatinib therapy or not?
Yeah, I mean, yes, exactly. That was our exactly our thoughts and concerns at that time, because as you mentioned, TKIs or tyrosine kinase inhibitors in pregnancy, they're not studies as with most of the anti-cancer drugs, right? So we have some evidence derived from the CML, which is chronic myeloid leukemia, that imatinib is used. And we have more evidence from that because actually 1/3 of patients diagnosed with CML are of reproductive age. So there is a little bit more prevalent than obviously GIST, that is a very uncommon scenario like that our patient was in. So in her case, what we consider as very high risk factors were two things. Obviously, it was the mutation of KIT exon 11 that they can tend to behave aggressively, but they are sensitive to imatinib. And the other factor was that the kind of surgery she had, there was tumor rupture, and the tumor was removed in pieces, so that, and she was only at 21 weeks pregnant gestation, right? So she had potentially up to at least almost up to 20 weeks of more to go with pregnancy. So we thought that was quite high risk. So we weighted the risks and benefits, and we decided to actually start her on imatinib when she was 20 weeks pregnant. So 20 weeks is almost it's actually at the end of the second trimester, right? So most of the organ development should have complete by now, but since it's taking place in the first trimester. So, and there's some evidence that imatinib, has been used in pregnancy before, either in CML or even in GIST cases. Obviously, these are case reports, and there were no adverse outcomes necessarily. So taking all those risks into consideration, we started her on imatinib. We started her at a lower dose, and then at 100 milligrams, and then we escalated every 3 to 4 days to reach the 400 eventual, their goal dose. So she did overall well. She did require 1 day to be off imatinib temporarily because her liver enzymes increased, but this was very transient abnormality. So we actually started her the next day, and she did well. So she tolerated treatment overall very well, as I said, but at 29 weeks of gestation, she actually went into premature labor. So we had to hold imatinib just for planned C-section, and she had an uncomplicated surgery at 30 weeks of gestation, and we restarted imatinib at that time after about a week. So her actually baby was preterm, obviously, and but eventually was discharged in stable health without any long-term deficits from either from the preterm labor or from the imatinib. So this patient in particular responded to imatinib for approximately 18 months totally, but she did have a very aggressive tumor in the end and progressed, unfortunately. So just to show you, this is the changes with the radiographic changes. You can see here on the far left, this is the CT immediately post C-section. So you can see these liver spots that are consistent with GIST and how they become, and these were already darker compared to her prior imaging that was done before imatinib. And as you can see, the changes that occur over time with the lesions becoming darker, as it often happens with GIST rather than shrinkage of the tumors. And then we reassessed the circulating tumor DNA about 3 months later. As you can see, that was non-detectable. And so just a few points from our cases. Our case is that cases of GIST in pregnancy have very scarcely been reported. In general, what we choose to do, if possible, is actually surgical excision, especially if the disease is not metastatic, and initiate TKI ideally postpartum for if adjuvant therapy is needed. And this is what it's been described mostly in the literature. As far as using imatinib during gestation, there's really insufficient evidence that imatinib can cause fetal developmental defects. And if that happens, it's usually if the exposure is in the first trimester where the major organs are developed. But if the exposures is after, there are a few cases describing some abnormalities. However, those patients did receive other medications that could cause that. So it's kind of hard to elicit whether imatinib really had any causative effect for these. Another thing to remember is that obviously the KIT mutation plays a huge role if it's imatinib sensitive or not, because even imatinib could be safe potentially after the second trimester. Other TKIs are not, for example, Sutent and regorafenib, and even the newest ripretinib and avapritinib. These are there's more evidence that actually these are teratogenic, so they would not be recommended to start the treatment during pregnancy because they have more of vascular effects compared to imatinib that doesn't share those activities. So in general, initiation of TKI therapy in pregnancy should be obviously individualized and taking into account the gestational age, meaning the time of pregnancy, and then obviously the status of disease and its mutation. In general, women who want to become pregnant should have a discussion with their oncologist first about possible risks and possible options. Just as a point in the end, the reason we check circulating tumor DNA is because during pregnancy, obviously, imaging should be limited, right? So, and for a disease like GIST in the abdomen and peritoneal cavity, we typically use CTs of the abdomen and pelvis, and radiation exposure to the fetus is actually quite high, especially with pelvic ultrasound CTs, and that's the reason we actually never got this for this patient. So we wanted to see if we could use a circulating tumor DNA as a surrogate to measure response in the future of that patient's pregnancy. Unfortunately, she went into premature labor, but had she not delivered at the time she delivered, she could potentially be on imatinib for at least 12 more weeks since we started her on. So we had to depend on that just to see how she's doing her disease is doing on imatinib. So hence we chose that. And obviously PET CT cannot be done during pregnancy because of the radiation risks. So this was my case, and then I can pass it on to, is it Dr. Kelly or?
Yes, thank you so much. We're gonna move on to Dr. Kelly for her presentation.
Okay, let me see if I can share this. Okay, can everybody see this okay? Yep.
Yes.
So So my case that I'd like to share today is that of a 35-year-old lady who presented in March of this year with lower abdominal pain, and unfortunately due to the COVID-19 pandemic, was delayed in her ability to seek medical attention. And so it was May of this year that she attended her GYN, local GYN, who examined her, felt a palpable mass on bimanual examination, and with a transvaginal ultrasound, it was thought that she had an endometrioma. So it didn't do anything further regarding this. And then unfortunately in June, presented acutely with a deterioration with severe abdominal pain, fevers, chills, and naturally went to her local emergency room. Just by way of her other background history, she had a history of hepatitis B and was on tenofovir. And with respect to her family history, had no children herself, one brother, aged 31, who was healthy. There was a family history of cancer in that a maternal aunt had colorectal cancer in their 50s, a maternal grandmother colorectal cancer at an unknown age, and then a paternal aunt breast cancer at an unknown age and deceased in their 60s. And so this was the imaging from the CT of abdomen and pelvis performed on arrival at the emergency room, and you can see a large abdominal mass. It was quite cystic, but there were additional smaller solid components, and it was felt to probably be arising from the small bowel, from a left-sided small bowel loop, and ultimately it measured 18 centimeters on CT imaging. She ultimately went on to have surgical resection emergently, and this the surgical specimen was subsequently reviewed at MSK and felt to be a small bowel gist measuring 17 centimeters in maximum dimension, spindle cell type and subtype, had cystic hemorrhagic areas, a low mitotic count of 2 per 50 high power field, and margins were not able to be assessed, so raising the concern for tumor rupture. She did have a limited panel, molecular analysis panel, that was negative for both KIT and PDGFRA alpha mutations. And it was about a month later that she sought a consultation at MSK. This was a telehealth assessment given the COVID-19 pandemic, and the discussion was really regarding the role of adjuvant therapy, which she had been recommended imatinib by her local oncologist. So just might open it up to Vaya and Sandra, just any thoughts that you might have about how you would approach this discussion, any points that you might think are relevant to bring up with the patient.
Sure, I can start first. Yeah, sure, thank you. Actually, it's a problem that we come across quite often for the non-imatinib sensitive mutations, right? What to do with adjuvant therapy. Obviously, adjuvant imatinib should not be recommended before we have confirmation of the mutation. That's the first point. And obviously this was done in this case. One thing to consider when we think about whether to recommend any adjuvant therapy in general is the risk of recurrence, right? If we go back to the adjuvant trials, actually the mutation status was not considered to register those patients in those trials, right? So, and that's where the problem comes, because this patient may have been qualified actually for those trials, but now that we know that she has, obviously we know more about GIST compared to that time when the trials were designed and were carried out, but obviously in her case, we know imatinib wouldn't really offer any benefit. Her tumor is resistant to that. So then it's really individualized decision. The only, I mean, the worrisome in this case was also there's a potential tumor rupture. And we know that if that happens, you know, this is high risk for recurrence, and those patients have, you know, outcomes are comparable to patients with metastatic disease, really. So that's another challenge. But there's no approved therapy for this type of GIST right now with with non-imatinib sensitive mutations, right? That's something to consider as well.
Yeah, absolutely, Vaya. You kind of highlighted a good few of the points that we brought up with the patient. So firstly, her margin status was unknown, and therefore the concern for tumor rupture, which increases their risk of recurrence. So hence discussing the role of restaging now as well to explore the extent of their disease. Regarding the adjuvant imatinib, it's recommended for patients, as you highlighted, with high risk imatinib-sensitive GIST, and based on this individual's tumor size and site alone, let's say they would be a high risk GIST, but then the outside molecular test results suggest an imatinib resistant molecular classification, although we do see false negative results. So I've personally seen that with the limited panels as well. So, I think it's prudent, to consider repeating just to confirm that we are indeed dealing with an imatinib resistant genotype, but also trying to determine what that genotype is. On the limited panel, we don't have details regarding what type of GIST we're dealing with here. Also of note, just, if you were considering imatinib, this patient does have a history of chronic hepatitis B infection, and therefore there is a risk for reactivation if you were to consider imatinib therapy. And like you suggested, via holding off on initiation of treatment is prudent here, not only because of the molecular status, but also in the setting whereby introducing it could cause significant harm with respect to the hepatitis B virus infection. And then also, the potential need for adjuvant imatinib therapy in a premenopausal woman. This brings up a discussion regarding family planning and fertility preservation given this patient's age. So the recommendations that we offered at the time were to restage the patient, repeat molecular testing, and to include germline DNA analysis given her young age. And there is, albeit a relatively small family or, limited family history of cancer, but there is one there nonetheless. So we felt that was appropriate. And then hepatitis B PCR to look at the viral load, referred for fertility preservation or specialist referral to discuss options regarding fertility preservation, and agreed to defer the introduction of imatinib until the results of these tests return. So with respect to follow-up, restaging CT and PET showed no evidence of disease, thankfully, and we performed MSK impact analysis, and the tumor's DNA results revealed an NF1 mutation. And then her germline results, interestingly, revealed a germline pathogenic NF1 mutation. So this patient now has a new diagnosis of neurofibromatosis type 1, which they were not aware of. And then on further questioning, they did reveal that they had some cafe au lait spots and possible axillary and inguinal freckling, but didn't note any other personal or family history of NF1 associated clinical features or tumors beyond this diagnosis. And I think this brings up a really important point that we are encountering now as we do more telehealth assessments. When we met this patient for the first time, it was a telehealth visit. So the ability to really detect those finer details of a dermatological examination on a telehealth visit, it's more difficult. And I think it just highlights the benefit of telehealth medicine is that, we can conduct these visits remotely, and which is really important. But also the importance of a clinical examination, which many times we've been fine so far, but I do think this case highlights that perfectly, that a physical examination is really important in many cases. So just a little bit about neurofibromatosis type 1. It's an autosomal dominant disorder. It's caused by a mutation in the NF1 tumor suppressor gene. The incidence is approximately 1 in 3,000 individuals. 50% of these are inheritable, and 50% occur de novo or sporadically. The diagnosis is really based on clinical characteristics, plus or minus a first degree relative with NF1. And so it's really a clinical diagnosis, although the confirmation of the germline analysis can also be performed in cases where in cases for confirmation. And then just this graph highlights the features that one can encounter with NF1, which those features can be very variable between patients. So we see pigmented lesions such as cafe au lait spots, skin full freckling, and Lish nodules in the iris, and neurofibromas, such as benign, so they're benign tumor growth on nerve sheets, such as plexiform neurofibromas, also dermal neurofibromas or paraspinal neurofibromas. Skeletal abnormalities occur early, including scoliosis, which is one of the more common skeletal abnormalities seen in this condition. Learning and cognitive and social deficits can also occur, and we see an increased incidence of ADHD and autism spectrum disorder also. And then low-grade tumors like brainstem glioma and optic pathway gliomas are also observed. And then in adulthood, we can encounter malignancies such as GIST, but also malignant peripheral nerve sheath tumors, which as sarcoma oncologists we see also. Breast cancer, there's a higher incidence, and also high-grade gliomas and pheochromocytomas also. So further recommendations. So I'm not sure if Sandra Baya would have any further recommendations at this point now that we have all that information to our knowledge now.
Yeah, I mean, I think that's obviously it's a challenging situation, right? Because the patient has high-risk disease, but then there are no approved treatments for GIST that carry NF1 mutations, right? And then there's obviously the very important point that if she's planning to, to have children, how, how can we make this happen, right? I mean, the good thing is that this is in the adjuvant setting, at least, so she doesn't have metastatic disease already, which is a good point. And so, you could prioritize her family planning first. And yeah, I think it's obviously her patient's decision as well. Obviously weighs in a lot in this.
Yeah, and I think in cases like this, the surveillance is extremely important to look for any new masses or tumors that may be benign or may turn into a malignancy, and to do thorough exams in person, head to toe, which we're not able to do as frequently as we'd like, and also imaging to. If there wasn't a recurrence, the key is to catch it early and maybe just do some local therapy to control it as well.
Yeah, so I completely agree with both of your important comments. So from the GIST perspective, we suggested expectant management with regular clinical and radiological follow-up. And we suggested a CT in 4 months just with the tumor rupture concern. She is at higher risk for recurrence and wanted to pick that up early, as early as possible if this was to occur. From the NF1 perspective, Sandra, as you were alluding to, a referral, to a geneticist to discuss this and the implications for this individual's extended family. Also, MRI brain, given the potential concern for potential finding for gliomas, etc., that was organized as well. And then from a family planning perspective, this lady had already was already on the path of discussing fertility preservation, and this new diagnosis does have implications on this. So with respect to the genetics consultation, which I always find really informative to read their recommendations, they ultimately advised individualized genetic counseling for all family members at risk to share the NF1 mutation, and at least annual physical examination. This will be more frequent in patients diagnosed in childhood. This will be more frequent, but in adulthood, at least annually. Ophthalmic examinaminations, including slit lamp exams, should be undertaken annually during childhood and periodically thereafter. BP monitoring, as I said, there is a potential risk for pheochromocytomas and other vasculopathies in this condition. Consider MRI brain, and also whole body MRIs are also considered for neurofibromatosis surveillance. Annual mammography at beginning at age 30 with consideration for annual breast MRI, with contrast from ages 30 to 50 due to the increased risk of breast cancer in this population. And then utilization of the genetic testing results to inform reproductive decision making, including the potential use of donor gametes, adoption, and then the option also of pre-implantation genetic diagnosis, whereby this is a reproductive technique used in conjunction with IVF that allows for selection of embryos that do not have the specific genetic mutation. So that's the, and bring my case to a conclusion, and if there's any questions, we can maybe take them at the end or now, whichever.
Nothing's popped up, so let's wait to the end, and participants can think if there's any follow-up questions that you have. I think one of the lessons learned is nothing is as it seems when you first see a patient. You have to dig a little bit deeper, and hopefully participants know it's critical to get mutational testing in these cases, because that really helps determine treatment path. So thank you very much, Dr. Kelly. I'd now like to turn this over to Sandra Brackert from UCLA, and you can go ahead and share your case presentation.
Thank you. I didn't do slides, so I'm going to read off notes. Bear with me. I want to start off with just doing a definition of survivor. Survivor is one who remains alive and continues to function during and after overcoming a serious hardship or life-threatening disease. In cancer, a person is considered to be a survivor from the time of diagnosis until the end of life. We'll come back to that at the end of my talk. My case involves, it starts when the woman was 45 years old. She had no symptoms, but she felt a mass in her abdomen. This was in March of 2011. Imaging showed an 8-centimeter right retroperitoneal mass involving the duodenum. She also had uterine fibroids and suffered from heavy menses due to this. In April 2011, a biopsy showed that she had a duodenal cyst, exon 11. We started her on neoadjuvant Gleevec, 400 milligrams daily in May of 2011. A follow-up scan in October 2011 showed that there was a response to the Gleevec, and there was a decrease in the duodenal mass, and she did not have signs of disease anywhere else in the body. Unfortunately, she suffered quite a few side effects on the imatinib. She had the usual paraorbital edema, bloating, nausea, some vomiting, but she also had increase in her liver function tests. So we had to actually hold Gleevec and ended up reducing the dose to 300 milligrams a day. Because of this, we said, well, let's bring her to surgery. So in December 2011, she had the resection of her cyst, but it was at a precarious location in which she would have had to undergo a Whipple procedure to entirely get clear margins. The surgeon decided to not do a Whipple procedure, but to do a resection of just the duodenal area. And the entire mass was removed, but microscopically, there was a little positive focal margin. So we restarted the Gleevec at the reduced dose of 300 milligrams daily. And the LFTs remained slightly elevated, but okay, side effects were managed. And she continued Gleevec for the next 3 years until March of 2015. At that time, she decided to stop Gleevec. We had a conversation. I won't say that we encouraged her. I think we encouraged her to stay on the Gleevec, but her decision was to stop it. So we supported her, and because of now not being on Gleevec, it was even more important to continue with the surveillance imaging. As we've seen in other cases, we want to catch things as early as possible if they were to recur. So about 3 years after being off Gleevec, a surveillance scan in July of 2018 showed a new 15 by 19 millimeter nodule in the right upper quadrant. I guess I'll stop here. Mine's going to be pretty straightforward, but what do we do in this case as far as treatment decisions?
Sandra, can I just recap on a few things if that's okay? So
Sure.
the patient had a duodenal cyst, imatinib sensitive, started imatinib, complications with some liver dysfunction, but managed appropriately, continued on. Did they move to surgery at any time?
Yes, I'm sorry. After about 6 months on the neoadjuvant payback, had the surgery, but instead of a Whipple procedure, underwent just removal of the duodenal mass. So had a little focal margin, was positive.
And then now
free, yeah. Then went on payback for 3 years.
And we're seeing something in their liver. Is that where?
No, just another abdominal mass.
Okay. So I suppose the concern is that this is a potential recurrence.
Yes. Yes. Okay. So yes, that's a recurrence.
And have we confirmed it with biopsy?
Yes.
So yeah, that's a really good question. So this is now we're in a recurrent metastatic setting, so where we rely on systemic therapy together with local interventions where appropriate. So, I would be inclined to consider resuming imatinib, but also then consider the option of local intervention after a period of time pending response, and also maybe helpful from a looking at mutational analysis as well. That's what I suggest.
So that's exactly what we did, and exon 11 still. And so we resumed the imatinib, the Gleevec, and we resumed it at the 300 milligram dose again. And her LFTs remained slightly elevated, but okay. And then we started scanning about every 3 to 4 months to evaluate. I'm happy to say that June, her latest scans, June 14th of 2020, the latest MRI was NED, no evidence of disease. So I give this case, it's a little more common, I guess, situation in which we have someone with a responsive GIST that either for whatever reason goes off of therapy, or there is a recurrence and we have to change therapies. But before I go down another rabbit hole, I just want to point out some of the side effects that we had to deal with, and maybe discuss that a little bit as well. So interestingly, when she went off of the Gleevec, she thought life was going to go back and be really great as it was before. And we're not sure if it's the age, as she was also perimenopausal when she went off of Gleevec, so that maybe some of the symptoms were related to menopause or what. But what she experienced is when she went off of Gleevec in March of 2015, 2 weeks after stopping, she experienced severe neck and shoulder joint pain. So much so she couldn't raise her hands over her head, couldn't wash her own hair. Her knee joints ached, her knees buckled. For 6 months, she was seeing specialists, trying to resolve this joint problem. And her feeling was that the edema that she had from the Gleevec actually soothed her joints in some way. And then maybe going off of the Gleevec and with the menopause, she developed a scar tissue in the neck and the shoulders. And in her case, about 6 months with dealing with this, she saw a masseuse that did a very deep massage and said that she was able to break down the scar tissue, and she was able to raise her hands again and resume her normal lifestyle. So it's just something to think of. We get usual side effects, and then we get some of these more out of the box side effects, and trying to figure out where is the cause, how can we help with them. So I just wanted to mention that. And then I also wanted to talk a little bit about the time when the recurrence happened. And so I discussed with her, how was that different when you're diagnosed with a recurrence versus primarily finding out you have cancer? And I just want to do a little bit of quoting from her. And she said that the most overwhelming feeling that she had at the time of recurrence is that I'm not a survivor anymore. She had taken the term survivor as someone that was cancer-free. And at the time of recurrence, she was not cancer-free anymore. It had come back. And so she really had to wrap her head around that I am a survivor. I'm still a survivor. I'm a survivor now more than ever, actually, is how she feels. Also, at the time of the recurrence, she didn't want to tell many people. At the time of the primary diagnosis, it's easy, more easy. People are wondering what's happening. She could tell them, I've been diagnosed with cancer, I'm on this treatment. And then all of a sudden she was telling those same people, I'm cured, I'm NED, no evidence of disease. And then it comes back and her whole definition of what she was feeling changed. And she says she hasn't told many people that it came back because she just didn't want to tell people. It was too hard to explain to people. People were saying things like, so glad that you are a survivor, so glad that you are cured. And now she has to tell them, well, it came back when I'm back on treatment. And it's just too much of a conversation to actually have. The other thing I wanted to point out, kind of a unusual side effect, is she was diagnosed with vaginismus. Vaginismus is sometimes, how it presents is she described it as a wall in her vagina. And it was like a wall against any kind of penetration from her partner. And she did see a gynecologist and was evaluated with a normal pelvic exam. And so the definition of vaginismus is usually caused by a trauma of some kind or a stressor, whether it's physical or psychological. And she actually relates the recurrence of the GIST tumor and going back on Gleevec as that stressor that has caused this for her. So I just want to say, we have to really look at all of the different psychological, it's mind, body, spirit, I guess is what I'm saying. And part of what we do is we treat the GIST tumor, and we also treat any other symptoms, side effects, et cetera, that one goes through. And each person's journey, as we know, is completely unique. And as care providers, we're very sensitive to that. And so that's all. I just wanted to also point out, she did find a lot of support online, which was very helpful. And such groups as the Life Raft group are really helpful for our patients to get this kind of support and this kind of information and conversation.
Sandra, can I just make a comment? Thank you so much for sharing this case. Although you said it was probably more common, but the aspects that you highlighted there are so important. And they're often maybe not recognized sometimes, and they're probably what the patient is truly having to deal with day to day more than anything. So I think can I ask you, how did the patient share that information? Was it upfront, or was it kind of with a little bit of time that they opened up to you about all of that?
That's really an interesting question, because in our clinic setting, we're really short on time. We have patients scheduled every 15, 20 minutes, and we spend the bulk of our time addressing life and death. And so it's rare to actually be able to have time to get into the psychological, the emotional, It actually just happened over time. And I actually telephoned her and had a discussion with her. And so maybe it was easier to discuss some of these things, not face to face, but over the telephone. Plus, this patient in particular is very open with sharing. So
I guess that highlights the importance then of continuity and getting to know your provider and nurse practitioner and being comfortable opening up. Yeah. And also kind of highlights the terminology that we use and that, you know,
yes.
what this signifies for people. And yeah, like we need to be more conscious of that and maybe trying to move away from that.
Yeah, I agree.
Thank you so much, Sandra. I agree with Dr. Kelly. I think that you got to treat the whole patient. And I think you were able to highlight from your perspective some other things that were going on for the patient or how they're, you know, how they viewed their journey. And that's so important to address along the way. So thank you for providing that perspective. I do have some questions that came in, so I'm going to go ahead and get started. So first is somebody had asked, can GIST be passed on to a baby in utero, especially if there is tumor rupture? Anybody want to take that? Dr. Floro?
Yeah, I can try. Yes. So, I mean, it's a good question, actually. And it's really difficult to answer, but I would say that this is less likely to happen, meaning of how the tumor rupture, if the tumor ruptures, usually it will happen in the, in the abdominal cavity, at least in the patient I presented. Which I guess in certain, that means that some may pass through the circulation and that can potentially pass through the placenta. But then we have to think about a placenta is a filter, right? So not everything passes through. It has to be of specific size. So that's why I would say it's less likely. But it's an interesting question, though, but I don't think we have the answer to scientifically, to answer this, but I wouldn't think it's a possible scenario.
Okay.
Yeah, I would agree. And I wonder if, ctDNA could help in that scenario too. You never know.
Okay, so one person says, I often get tired of being asked about my health issues, GIST, breast cancer, nasal basal squamous cell removed. I'm too busy learning stuff and living life to wallow in the poor me people want me to express. I feel people want me to proclaim my survivorship from the rooftop. I'm not interested. I don't consider my health issues my primary self-exception, primarily self-identification. I seem to be the exception. Are there other patients that feel like this? Have you encountered that in any of your practices?
Yeah, I mean, if I start, so I think it's as actually Sandra is a very, very good case to present the impact of cancer diagnosis in general and individual, and that varies a lot, right? And it's regardless of the stage. We often, as oncologists, think, obviously, when we approach a patient with something that has something potentially curable, we focus on that. We make sure that the patient knows that this is a curable malignancy. So we're going to try our best to help you through this, so we never think about it again. But the reality is that sometimes, disease returns, unfortunately. So, but the impact that this has on patient, it varies significantly. I would say most patients are affected, and now the degree of it's variable. I've had patients like this question, this person questioned that they didn't tie the diagnosis and their identity. So they didn't feel like they would have to talk about it all the time. And that's absolutely fine. Obviously they're oncologists, so they have to talk about it with us. But the amount they choose to share with their family and friends is really up to them. What we encourage patients is to at least, have their the close family to, be aware of their journey, regardless of how many details they want them to know. But after that, it's really up to them.
And I think that everybody has a different way of handling a diagnosis, and also having like a support group, and tapping into something like the Life Raft group would be helpful if you need the support to talk to somebody, or if you need the information and education. And people take different angles for what they need. So just kind of chiming in about that aspect. Okay, so somebody had mentioned that they have a history of stage 3 GIST, small intestine. It was removed, 6 by 9 centimeter, good margins, 2.5 years ago. They've been on imatinib, 400 milligrams once a day since. Person's been struggling with nausea and diarrhea mainly, taking imatinib 30 minutes after lunch. Zofran makes them constipated. But they're struggling. They're really struggling working from home even. And the CAT scan says NED, and the tumor had a high mitotic rate. So she's getting scanned every 6 months without oral contrast. I think the question is, do you still recommend to get the oral contrast and even to continue with the imatinib as long as they can tolerate it?
I'll jump in with this one because I think it kind of pertains a little to my case as well. We do know that it's much safer to stay on Gleevec. Originally, we weren't so sure how many years on Gleevec, but the more research we're seeing, it's definite. The longer you stay on it while you're getting response from it, is the better to stay on it. And manage the symptoms. As you saw in our case, we had to reduce the dose a little bit. So that's something to talk with their physician about, and see whether maybe dropping to the 300 milligram dose would help a little bit with the side effects. As far as the contrast, usually we do want the oral contrast. So we would encourage him or her to continue with the imaging with the oral contrast.
I just want to ask a question actually about that as a follow-up, because sometimes people are on Gleevec for a long time, and there is some questions about how the contrast might affect their kidneys over time. So what would you recommend to a patient who has had oral contrast over a long time and maybe their creatinine levels have elevated, and how would you monitor that?
I can jump in there. So I believe it's more the IV contrast with respect to the kidney impairment. It has the potential to cause a contrast-induced nephropathy. So there is certain criteria as regards what level is okay to continue with using contrast. I would advise all my patients having contrast CTs to hydrate themselves pre-CT and post-CT, but in particular pre-CT, getting it, and then ensuring that their renal function is okay before the test, and it will be, obviously, if they're on treatment, it will be monitored anyway, but if not, having regular kidney function testing is reasonable given the need for the CTs. And then for patients whereby they do have an issue with, let's say, a renal impairment, there is also the potential role to use an MRI as an alternative, which doesn't, at lower creatinine levels, doesn't have as significant an impact on increasing the risk of renal impairment. So for patients with more end-stage renal disease, there are issues with performing MRIs with gadolinium, but for those with lower range creatinines, it's generally safe and can be just as effective in terms of imaging, I feel, from a point of view of GIST.
Thank you. Another person asked, how would you treat differently for an exon 9 versus exon 11?
So, will I take that one? I guess it depends on the setting that you're asking that question. So in the metastatic setting, we know that increasing the dose is associated with increasing the dose of imatinib to 800 milligrams in patients with KIT exon 9 mutations will be a standard of care and associated with better outcomes. In the adjuvant setting, though, we don't really have data to support doing that. So generally in the adjuvant setting, I would recommend the standard 400 milligram dose.
I'm just kind of wading through some of these questions. Somebody said, are there any interactions with birth control pills and current therapies?
Not that I know of.
Okay. I would say that as an overall, there's a lot of commentaries in here, just so all the panelists know, people who feel like they can relate to some of the cases that were shared, and looking normal, but feeling scared and angry about, I guess, different parts of their journey, if a recurrence happened and the conversation with their provider. Others who said they can really relate to the patient that Sandra talked about, aches and pains and in the neck, joints, being 51 and menopausal. So happy to hear that maybe it was from going off Gleevec. Never thought of that till I heard that patient's story. I'm hopeful it will be a lesson over time. So I think what each of you did was kind of give the people here hope that they don't feel alone, that there's specialists out there that know how to ask the right questions along the journey. And I would say as like a closing question that came in is, I think that you have a fan club now, because some of the people want to know if any of you are doing telehealth consults for second opinions. So if so, how does one schedule one? Who would like?
That's really kind, and I guess the hope is here that we do give hope to people, information, and we're, you know, I'm sure all of us are more than happy to meet with any patient. Yeah, at Memorial Sloan Kettering, we are offering telehealth medicine visits. And Sarah, I think we had shared the details with regards to how to connect. So more than happy to meet with anybody who feels there's a need.
And same with Huntsman and UCLA, you're both doing telehealth? Okay.
Yeah, I work actually with two physicians, Dr. Arun Singh and Dr. Bartosz Szymlowski, and we definitely do telehealth visits.
Well, if anybody would like that information, the Life Raft group is happy to share that information after this seminar today. So feel free to reach out to us. I just want to say thank you to each of you. I think today was unique, first of all, because we're just embarking on this Women in Sarcoma series, but I think what you did was you provided each of your unique perspectives into the cases that have come into your clinic. And I think that's a window for all these patients out there to see how you go about diagnosing these cases, how important it is to actually not just virtually see the patient, but also physically to see the patient, but also listen to the whole picture, the psychological, emotional, mental components as well. So I think that that's what makes you ladies unique. And I hope that everybody can understand and convey that that's why we're highlighting women in sarcoma. And I want to thank you all for being there for the GIST community. And we hope to engage with you further down the road. So thank you for participating today. And thank you to all who've joined us. And looking forward to our next